Hello, everyone, and welcome to episode 24 of the Ortho Eval Podcast. This is your host, Paul Marquis, and do I have a treat for you today? On the show today, we have guest Lenny Macrina from Champion PT and Performance down in Boston. Welcome, Lenny.
Thank you for having me. It's great to be on. Love to share some knowledge and hopefully just get the word out on what we're doing.
So Lenny, I really appreciate you taking the time to do this. I know you guys are getting a little snow down there in Massachusetts today, aren't you?
Yeah, it's a little snow, about 15 to 20 inches. So we'll deal with it and we'll go back to work tomorrow.
Super. That sounds good. So I know this is kind of last minute for you, and I really appreciate your time. I know that you're a super busy guy, and I really appreciate this. So a little bit about Lenny. He is the director of physical therapy at Champion PT and Performance, also the co-founder, and has worked side by side with renowned orthopedic surgeon Dr. James Andrews, and also with prominent physical therapist Kevin Wilk. I love those guys. I've been to their courses.
Mm-hmm.
I follow Kevin Wilk's stuff to the T, and they've been really great advocates of what we do, and really passionate about getting people better in the orthopedic world. So that's been a super thing. And so you also are really well respected in the field of orthopedics and sports medicine. I know that you've been a physical therapist and a certified sports physical therapist by the American PT Association. Also a certified strength and conditioning specialist by the National Strength and Conditioning Association. So you've been a physical therapist since 2003, correct?
Yeah, about 15 years now. Yeah. So thanks for the introduction. I know Dr. Andrews and Kevin are big influences in my life, and also my business partner Mike Reinhold as well. He's definitely influences me and pushes me daily because he's my business partner down at Champion in Boston. So don't want to not mention him.
No, I know. I listen to everything you guys do, and it's absolutely super. I mean, I really like that, and your shows are absolutely awesome. So we're going to keep looking at them. I know everybody here at our staff, we have 14, 15 therapists on staff, and most of them watch everything you guys do, and you guys are really well respected up here in Northern Maine. So
awesome. We appreciate it.
Really appreciate that. And one of the reasons I had you on, Lenny, is because of your passion. I watch you. I watched some of your podcasts and listen to some of your blogs and things like that, and your passion to get people better and to do a little bit more and go above and beyond what everybody else is doing is just absolutely spectacular. So that's really the number one reason I had you on. I know you're loaded with knowledge. Talk to me a little bit about some of the journals that you've had some articles in.
Yeah, I mean, when that was my time back in Birmingham, we do a little bit now, but when I was with Kevin and Dr. Andrews and Glenn Fleissig at ASMI, the American Sports Medicine Institute, that was just a hotbed. It was just basically an area where we could just do a ton of research and get stuff out. So working with Kevin gave me access to be able to do that stuff. So we would publish some of our data, especially that we did in baseball, some of our spring training data that we did with the Tampa Bay Rays. Actually, we started off collecting the data with the Tampa Bay Devil Rays, and then they became the Tampa Bay Rays, used a lot of that data to publish some of our stuff in JOSPT, Sports Health, the American Journal of Sports Medicine, Clinical Orthopedics and Related Research, some of the big journals that I think are the more popular journals that PTs and doctors kind of go towards when they're looking to gain some knowledge. So it was a good opportunity. And Mike and I are actually got a paper that we're putting out right now. That's going to go in the Sports Health Journal. That's one of the journals you get when you're a sports section member of the APTA. It's going to be on weighted balls. So with a lot of baseball kids and adults are using weighted balls to try to increase velocity. So we get that paper that is in review right now in the Journal of Sports Health.
Awesome.
Yeah.
So you treat a lot of pitchers, baseball players, I take it?
We do. Yeah, that's kind of our niche down in Boston is baseball. Baseball pitchers, especially catchers. But then we also have 3 other therapists as well that work in our practice. So we get a ton of gymnastics, we get a ton of CrossFit, and we get some golfers as well. And just the regular athlete, not just professional athletes. We have a small portion of what we do, but we get athletes of all types that come into our facility. So we see it all, kind of on a higher level. But still, we see people either post-surgical or just trying to get better. They're not hurt. They just want to improve their performance. So they find us.
Right. I think people are becoming a little more aware of the need to do preventative medicine, be healthy before they have an
Correct.
injury.
Yeah.
And I think that's a real growing thing. We're seeing it even up here in Northern Maine, where we don't see high level athletes, but we do a lot of 3-sport athletes. And so that we're seeing a lot of that. So that's a really good thing for especially our youngsters who are coming up and want to do some higher level sports stuff.
Yeah, I mean, having being in Massachusetts, we have full direct access. I don't know what the rules are in Maine, but we have full direct access, which means people can see us as much as they want, and they take advantage of that. They I think they know those rules, or they don't realize that a lot of times you need a prescription in other states. So they just think you can come to PT and not need to see a doctor, and they're fine with that. And we are the first line of defense for a lot of people.
Absolutely.
And we're a referral source for many doctors in the area. We're sending people to Mass General, Brigham, Beth Israel Hospital, Brigham and Women's. We're sending people all over as a referral source to surgeons if we think something's going on that needs a further consult.
Yeah, absolutely. And in Maine, same thing. We have direct access, and I see people off the street on a daily basis.
Yeah.
So, while we're on that topic, because you and I see so many orthopedic and sports patients, we oftentimes we'll have to put a diagnosis. And when we go to school, they say, well, you're a therapist, you really cannot diagnose
Right.
patients. Okay. But I mean, how often do we get a diagnosis that says a shoulder pain and we have to figure it out? And then we have to really put that program to that diagnosis. So, let's say somebody comes in and they're referred to you by a physician, and you are dead set on a different diagnosis. They've come in with a certain diagnosis, and you think, you know what? I've seen a lot of this. I really know what it is. I know it's not that. I want to treat it like this. How do you approach the physician in that situation? What is it that you like to do? And what makes that transition as smooth as possible without being kind of offensive toward the physician?
Right. First off, I never want to be offensive to another medical professional. So that's number one. Never try to make a doctor or another PT look bad. I tend to wear my emotions on my sleeve. If you haven't figured that out in the podcast, our Ask Mike Rhino podcast. So I do my best to not make anybody else look like they were inferior to me, because I certainly don't know everything. But with that, we do see that frequently, that people come in with a diagnosis either of just shoulder pain or I don't know, maybe it says impingement, it's kind of that wastebasket term. And you dive a little deeper and it seems to be cervical spine, or maybe it's thoracic outlet. We see a lot of that in baseball players. And we need to make an appropriate diagnosis, because that's going to affect our treatment. We're going to treat thoracic outlet a lot differently than a shoulder impingement type thing or diagnosis. So I will be pretty straightforward that this is what I think is going on. These tests tend to prove what I'm finding, and I will treat it as that way, again, because I can do that in my state, and I can do that not necessarily under the guidance of what the doctor is saying, but because I'm treating the symptoms. I'm treating the presentation, not the symptoms. So I'm treating if they are having some kind of thoracic outlet, or if they're having some kind of what appears to be rotator cuff, but it's labrum. I'm going to treat the presentation. I'm going to treat the movement dysfunction more so than anything. I'm not treating a pathology. So, they tend to buy in pretty quickly when I go towards that line of talking, and it tends to win them over. And again, my situation's a little different. I'm not dealing with insurance companies, so I'm not dealing with I'm out of network. We're cash based, our clinic, so it's a little different. That I don't need to have a specific diagnosis, because I have to come up with the ICD-10 code for people, but that's going to be on them to have to get reimbursement from the insurance company. I'm treating them. I'm treating their presentation. We do it with an SFMA or some kind of other screen. We're screening them, and that's what we're treating.
Right. So, a while back, I had done an episode. It was episode 10 in the Ortho Eval podcast. It was how to connect with specialists better. Do you have any tidbits of information that would be really, really good for young physical therapists who are very frustrated with trying to connect to a specialist? And you know how difficult it was when you were a new grad, you came out of school, you were nervous talking to physicians, and you just wanted to get yourself introduced and into the picture. And I have a bunch of tidbits in that particular podcast, but I'd like to hear from you. what would the young therapist do to try to connect? And it doesn't even need to be a young therapist. It could be an FNP, it could be a PA, it could be an athletic trainer who really wants to connect to that physician. What are your thoughts on that?
Yeah, that's a tricky one because I was fortunate when I was in Alabama that I had access to the docs. Almost 24 hours a day. I could and I almost still do. Those guys, it depends on the doctor's group, really. Because right now I could text Dr. Andrews, world-renowned orthopedic surgeon, and I guarantee he responds to me within a half hour at the latest. It would be longer if he's in the middle of a surgery, but the relationship that we've built with doctors, not only in Birmingham, but even in Boston, that I can send a text message to somebody and just get the word out on an opinion, or, hey, can we chat? I get something I want to share with you. How that happens, I think it's not necessarily in that professional environment, meaning I'm not going to their office all the time and bringing them donuts. I think we're going down the wrong avenue with that. I think it's going to meetings. It's going to meetings in the area. MGH has meetings. Beth Israel has sports meetings. Harvard has meetings in the area in Boston. I speak at the injuries and baseball course that ASMI puts on every year. I mean, there are doctors just roaming the area, and they see you doing that stuff, speaking at these places. You now take things to a different level when you're speaking to them. You can now approach them, I think, often in the crowd, or just at dinner or at a luncheon, and just chat with them and I did this the other couple months ago with Dr. Chris Ahmad in New York. So he's at Columbia Presbyterian Hospital. He has sent us some people, but I had never met Chris Ahmad. This is the team doctor for the Yankees. So I went over, approached him, just want to introduce myself. I have access to, I got his cell phone, I have his email. I can do anything I want with Dr. Ahmad now, because he now sees me as a peer. He sees me as somebody he can trust with information. He sees somebody that he can trust with an opinion. And that's a game changer for PT, is to be able to get that communication with the doctor and the PT and the athletic trainer and the PA, anybody that's involved in that in that person's care. It's a game changer. Trust me, to be able to communicate on the same level with the team. I think that's why they're so successful in Birmingham. That Dr. Andrews and his group, and now he's down at Gulf Breeze. But Kevin and myself, when we were down there, we had, like I said, open access to that group. We could talk to them whenever we needed them, and we still do. Funny story about Dr. Andrews. I called him last September about somebody who had PRP injection in his elbow, and I called his cell. He answered his phone, and he said, "Hey, Lenny, what's going on?" He said, "Hey, Dr. Andrews, got a question about so and so." And he said, "Hold on, I'm in a cafe in Venice." So he's sitting in a cafe in Venice. Now, they were 5-6 hours ahead of us. So it's probably 8-9 o'clock at night. He answered his phone. He said, "Hold on, let me get into an area where I can talk with you." And we started talking about this kid's elbow while he's sitting in a cafe in Venice with the team owner of the Washington Redskins. You know what I mean? So he stepped away from Daniel Snyder, essentially, to speak with me about this college kid's elbow. So that's the relationship that you need to have with your surgeon or your referral sources,
Right. I think that it's important that when you send a patient to a physician, that you have you understand the diagnosis, you get the diagnosis right. Correct. When you send it to them, and that may take a little extra research, especially as a young therapist. Talk to your colleagues, talk to your mentors, break open the books, look at some of the information, look at the specialists like yourself and Mike Reynolds and ask those questions, and make sure you have the diagnosis right before you go to the orthopedic surgeon. And I think that's huge, so that they know that you understand what you're talking about. And they'll develop some trust in you that way. The other thing that I've done with them, I've never bought a donut or a meal for a doctor, to be honest with you, because I think we've built a reputation. I have a cell phone full of cell phone numbers. And that's pretty cool, because when we need them for really important things, they'll talk to us, and they know that we're going to call, and it's not going to be about a hangnail. It's going to be about something that's serious. Right. And so that's, I think that's one of the ways you need to really build that reputation with the physician. Make sure that you utilize their time and respect them and respect their time. And I think that's big. Right. Yeah. Definitely don't cry wolf. You don't want to abuse that privilege, and you don't want to make them look bad. Like, I know I know you said it's impingement, but I definitely think it's cervical spine. You just don't want to make them look bad. There's definitely egos involved, especially when you're dealing with orthopedic surgeons. So they know it. I joke around about it, but I think it's true. And I think we all have our little egos about ourselves. So we just need to, clearly present our case and confidently, and, again, go treat the findings, not necessarily treating a diagnosis. So. Right, right. And I always ask them also before, I always say, how do you like to be contacted? What is the best way that I can get in touch with you, and what works for you? And I have some physicians that say, I don't answer my cell phone, but I email all the time. So I'll email a neurosurgeon down in Portland, Maine, and between cases, he'll respond right back to me. But if I text him, I'll never hear back, So knowing what they like, putting it in their ball court is important.
Right. Definitely.
Super. So Lenny, let me get into a couple of questions about some orthopedic physical therapy things. If you are treating a patient with impingement syndrome to the shoulder, how long do you like to treat him in therapy and treat him conservatively before you say, you know what, I think there's something else going on here. We need to intervene. We need to get an MRI, an injection, or send this patient to an orthopedic surgeon. How long do you like to generally go with those folks before you make those decisions?
Yeah, it varies, but I would say I get a good feel with somebody after, I would say, a few visits. Like, it doesn't take long for me to, if they should be able to feel a pretty, not a significant change, but they should come back and say, I feel a little better, or I think we're going down the right path after a couple visits. And for me, a couple visits is a couple weeks, because I'm seeing people once a week or once every other week. I'm not seeing people 2 to 3 times a week, like the prescriptions generically say. So that once a week, I see somebody, I give them exercises, and they're going to do them at home. That next time they come in, they better be feeling a little better. If they don't, I'll give them a little bit more time. I'll give them another session. I'll give them more time to do their homework, their home exercise program. And then, 2, 3, 4 weeks at the most, I'm starting to turn the wheels are going off in my head, and I'm thinking, all right, we either have to, pivot and change what we're doing, or maybe they need further assessment. Maybe they do need to get a referral to a doc to get an injection or an MRI, something like that. So I would say pretty quickly for myself will be, 3, 4 weeks at the most, I think. I don't know if you have a different take, Paul.
I usually go 4 to 6 weeks, and it's only because we may see a little different population of patients than you see, and so I give them a little bit more time and do a lot of education on how to avoid the impingement. Not a lot of cross body motion, not a lot of overhead activity, retraining the scapula muscles. But sometimes getting them onto a little non-steroidal anti-inflammatory seems to help settle things down a little bit if they can tolerate that.
I will also say that when I say at 3 or 4 weeks, hey, maybe we want to go to the doc, but if we go to the doc, surgeons want to do surgery. So if they do an MRI, they're probably going to find something on your shoulder, because if we do an MRI on most people, they're going to find something. So you better be ready to want to have further treatment. That's not going to just be PT. Either it's going to be an injection, or it could be surgery if we open up this can of worms, called an MRI.
Exactly.
So Dr. Andrews used to always say, if you want an excuse to do surgery, get an MRI. And I tell that to people, and that it kind of opens their eyes and like, whoa, yeah, maybe let's just give it a little bit more time, and next thing you know, it's 4 to 6 weeks and we're hopefully cruising, or at least a little bit better. But yeah, it's definitely as long as possible. I am definitely an advocate to hold off sending them back to the doc as long as possible.
Yeah. Now I've seen these acute rotator cuff impingements that mimic rotator cuff tears. They're so inflamed and so impinged. Do you see that also, where they can barely lift that arm, or they're really hiking a lot? Do you see that?
Yeah, we do see that. And, the research is starting to, kind of be poo-poo on, not to use the word poo-poo in your podcast, but it's starting to not be so positive with surgeries. The more we see about knee surgery and shoulder surgery, it seems like people with even full thickness rotator cuff tears, they do almost just as well, statistically speaking. And if you look at some of the newest research, than having their rotator cuff repaired. That being said, I still think there's a definite place for rotator cuff repair. There are certain people that need that. They don't respond to non-op treatment, but I think a good course of working on range of motion, getting the shoulder to calm down, activity modification, anti-inflammatories that are prescribed by a doc or whoever else, PA or nurse practitioner, and just throwing the kitchen sink at them to give them a chance to calm the shoulder down, because if they do have a surgery, you don't want to go having a surgery when their shoulder's all inflamed, or B, give them a chance to avoid surgery. So to me, I'm going to throw the kitchen sink at them, and I'm going to be their number one advocate, their number one cheerleader to get them feeling better. I can't imagine, lying in bed, writhing in pain because my shoulder's throbbing, so try to put yourself in that position, be what they're going through. I think the empathy portion of PT is huge, and understanding what people are going through as best as you can, even if you haven't lived it. And I think if you see from their eyes, I think it's gonna push you even harder to do everything you can for them.
Absolutely. I mean, we spend so much more time with patients than physicians do. And, you really get to know them a little more intimately, and you understand their shoulder situation a lot better. So,
right.
So that's great. And then we actually had a shoulder fellowship trained shoulder specialist here in Maine tell some of our patients recently that, listen, I don't want to do shoulder surgery on your small rotator cuff there because the research is showing that PT is, doing just as well after 12 months. And that's really encouraging that the physicians are backing us up, and
definitely.
And as long as we know what we're doing and they have confidence in us, we definitely can head those people in the right direction.
Yeah, definitely.
Cool. Next question I have for you is regarding anterior shoulder instability.
Yeah.
Now, somebody dislocates their shoulder. It's acute dislocation. It's a complete dislocation. What is your thought on immobilizing them?
It depends. It depends on their age. It depends on their activity level. A younger person may want to immobilize them just a little, just to kind of slow them down. Younger meaning, that 15 to 22-year-old who's more likely to have a dislocation. There's a study that came out in, like 2004 maybe, that showed that the number one attribute to redislocating is age. If you are younger, you're going to probably redislocate just because of your tissue quality and your activity level. You just a little crazier in what you do. So I'll probably like to see them immobilized a little longer. In the 40-plus-year-old, so to speak, like myself, I'd probably, immobilization relative for pain tolerance. And once they get comfortable, probably try to get them out of there because they're probably going to get stiff. That 40-plus, their shoulder's going to stiffen up on its own. And we don't want to get them too stiff. Now, we want to get some early range of motion going for pain control and, collagen realignment, all that stuff that we work on, proprioception. But in that younger person, I would say immobilize them for probably a week or two, if possible. Get that shoulder to calm down, get that shoulder stable, and let that person know they need to slow themselves down a little.
Right. So you're an advocate of starting PT pretty early on.
Yeah, I guess that's
starting to get some co-contraction, and rhythmic stabilization, that type of thing.
My Birmingham upbringing, we got post-op day one, whether it's a surgery or injury day one, we got people in right away. And got them moving. I think it comes down to being able to educate the person. Otherwise, that person is just floating around without knowing what to do. They're searching Dr. Google for some information on what they should do, and that's very worrisome when they start Google searching, because now their minds start going crazy with what they should be doing, or how come I'm not doing this? Why am I feeling this? And they have no outlet. They have nowhere to go. They're not going to call the doctor and get an opinion. The doctor's not going to necessarily get back to them. So I think getting us in the equation early on to be able to educate, get some range of motion going on early, give them maybe some isometrics, give them education on brace use, give them education on heating and icing and some modalities they can do at home. I think that's invaluable for them. And it gets you that early care where you get to understand that person. And now they have access to you. I know in my practice, most people have my cell phone and my email, so they can email me or call or text me whenever they want if they have an issue. So, it's a Saturday and my shoulder's throbbing. What do I do? Probably ice it, something like that. And let's just get you on the schedule for next week, and we can do it that way. So I think being an advocate for the patient is huge. So getting them in the system early with somebody they trust, I think, is invaluable.
Right. Yeah, I agree. I did a Facebook post the other day about Dr. Google and gizmos and gadgets that people get too involved with, and really it scares me. I really try to keep people away from that as much as possible, and they really drive themselves down the wrong direction. Yeah,
definitely.
Next question I have is, I hear that you guys have a cash-based practice, PT practice.
Yeah.
Can you tell me a little bit about how that works? How long have you guys been doing that? I know that we've been talking about doing some things like this. We wanted to start we call the annual PT checkup. So instead of just going for your regular physical with your doctor, you get a real 1 hour with us. We look at everything from balance to your functional ability and all these things. And we'd like to use that as a cash-based practice, but I'm wondering, can you do some insurance-based practice and cash-based, or does it have to be all or none?
Yeah, it depends on your state regulations and all that, but I know all of us are out of network where none of us have contracts signed with any insurances. So that might be an issue. And it comes down to, I think, also the business's NPI. and also the PT that's seeing them, their NPI, what it's attached to billing wise. So I came from Alabama, so I had no contracts in Massachusetts, so I could just kind of come up here and not worry. We had one of our PTs, Dave Tilley, was working in Massachusetts, so he had to get rid of all of his contracts with Blue Cross, Cigna, Aetna, and all that, because if you see somebody and you are already contracted, you need to officially bill for in-network benefits, and you can't see them cash-based from what we understand. Now, we've had to deal with lawyers and all that to get all that comfortably understood. But for us, our cash-based practice, we're 5 PTs. We're in Waltham, Massachusetts. We see, like I said, a lot of high-level athletes, and we give an hour of one-on-one care with them. So, and we also have the fitness side of the business too. So it kind of, people go in and out from PT to fitness and fitness to PT. Hopefully not that often when they're coming to see us for PT after they're working out with us. But, everybody has little aches and pains that they want to be looked at, and we're here for them. So the business works well that they can go to the fitness side after they're, I don't want to say done with us, they're never done with PT. Again, like what you're saying, get that screen. People go to the dentist, twice a year for their teeth, but they're ignoring everything else in their body.
That's right.
So
that's right.
I think if you can somehow get people to understand the fact that your body is, that's your life, that's your survival, that's everything you got. And if you can move a little better, feel a little better, that's just going to make everything a little bit better for you. So we get a lot of those people that just want to feel and move a little bit better, and they're not necessarily in pain. And they find us, through Google searches and search engine optimization and blog posts and word of mouth. That's all of our referral. Our budget for marketing is $0. We don't market at all. It's all word of mouth. Great. So it can happen. It is possible. You just gotta, become an advocate and become a leader in your area of movement and strength training.
Yeah. Well, I mean, you look at deductible plans and stuff like that. They're all going through the roof. It's almost like everything's catastrophic.
Yeah.
And so if you're going to be spending $10,000 in a deductible, some of them, patients are now telling us, I just want to pay you to do the work. And so we're definitely looking in that direction. And I think there's a lot of practices out there that are really looking like that. So great. Well, that's good to know. So before we wind down, Lenny, tell me a little bit about LennyMacrina.com and what you're doing right now. And I see you've got some new stuff going. And so fill me in. Tell me what's going on.
Yeah. Working where I work with Dave Tilley and Mike Ryan and Mike Scaduto, they all have websites. So I would just always hear about WordPress and filters and all this stuff. And so last year, in mid 2017, I made the plunge and I built my own website. And so it was kind of my goal for my website, LennyMacrina.com, is kind of my calling card, that where you can find me for anything, and you can get in touch with me. You can get me to teach a course in your area. Or it's just where I'm beginning to put some blog posts out and some videos. So I think it's just getting comfortable writing, getting comfortable writing a blog versus I'm used to writing journal articles. So I'm used to, that's my mind is a completely different world writing a blog post than writing a journal article. So Mike has been a huge help because of his website, MikeReinald.com.
Right.
He's had that for years. So he knows how to optimize, search engines, so to speak, and let Google find you. So he's been helpful. And it's just trying to get my take on PT, my word on PT, and just simplifying things. I think we get a little too complicated in what we're trying to do out there. I think we're trying to attack too much, and we're trying to do too much. And I think if we can take a big step back and teach the basics again, and I think that's kind of the fundamentals of my website, is just kind of going back to some of the basics of what has been hopefully successful for me the past 15 years, and let people get a kind of glimpse of what I do. And it's not as complicated as you think, and try to get, especially new grads, comfortable with interacting with people. I think that's a huge thing. And then I'm also on social media too. I'm on Twitter and Instagram at LenMacPT. So it kind of feeds, I kind of use social media to kind of get people to my website, and just hopefully people would want to subscribe to my website and be the first to kind of catch a blog post from me. So it's just kind of simplifying the world of physical therapy. Yeah.
Gosh, I almost want to say ditto here, because I've been doing the same thing. I got into my own website, and that's been quite a challenge. I'm not very I am technically challenged, and so that's been it's been really fun though, because we enjoy what we're doing, and we're learning a lot as we get going here. And I think over the next year or so, things are really going to start jumping, and connecting with guys like you is super, and I think it's going to be really helpful. And so that's been kind of a process. I'm also building another website for a product that I've developed, and I'll shoot that stuff over to you at some point in the future. But that's just about ready to go live here in the next week or so. And so that's another little project. I just wish we, didn't have to eat, didn't have to sleep, and do all that other stuff, because we could just go crazy with this stuff.
Well, for somebody who's very technically challenged, you seem to be doing okay. You got your own podcast, so you got a big leg up on me. You got your own,
Yeah. I've been at this for 25 years and I absolutely love it. I've never had a day where I've come to work and didn't want to be here. I love what I do. I love my staff. I love helping people get better.
Yeah.
And I just want to take it to another step. We're in Northern Maine, so we don't have, we send everybody to Boston actually for like the really, really big stuff. And when we really need some backup, that's where they go.
Yeah.
And so we don't have access to sit down with those types of folks that you get a chance to communicate with. So I thought being online and doing this type of thing really will help us get it connected and let people know that, just because we're in Northern Maine, that we can still offer what the rest of the world offers.
Yeah, that's amazing. That's awesome.
Lenny, I really, really appreciate you taking the time today. I know you've got a family and a day off today, and I really appreciate that. This has been an incredible podcast, and maybe we'll do some more in the future with some different topics or something.
Yeah, definitely. I'm glad we connected, and hopefully we can connect in the future. So take care, and thanks for having me.
All right. Thanks again.
Yeah, thank you.